Good morning. So we're going to talk about the personalized treatment of colorectal liver metastasis and fact and fiction. I'd like to go back to the algorithm we have used for many years now to treat colorectal liver metastasis. We have had a focused eye on what we can resect, and we look at CTs and we look at tumors in a very focused and tunnel vision, and we want to resect. Of course, we're very tempted to resect. Every time we can resect, we resect. And this has been our goal for the past 10, 20 years, 30 years. And we have certainly improved the survival in patients with colorectal liver metastasis, but we have a long way to go if we want to further improve this survival and select better patients who we want to resect. And there has been paradigm shifts in the resection of colorectal liver metastasis that will further improve in the coming years the result of the resection with precision surgery, new technology, and use of molecular biology. And I'd like to focus for this talk on difficult patients with small metastases. So patients at the other end of the spectrum with bilateral colorectal liver metastasis, which require extensive surgery. And there are temptations with the small metastasis to go minimally invasive and perhaps sometimes making mistake. And on the bilateral bilobar metastasis, going all the way and going too far. There's also the underlying biology, and I will allude to the 5 related cancer pathway, which define the survival of these patients with colorectal cancer. And I will talk about circulating tumor DNA. For small metastasis, we know that the way to go now is to do parenchymal sparing surgery. And with parenchymal sparing surgery, we improve survival not only from the time of the first hepatectomy, but from the time of a second hepatectomy. So the salvageability is greater if we do parenchymal sparing surgery. 95% of patients today undergo resection after chemotherapy. And an important aspect of the treatment of the small metastasis is to look at the CT prior to chemotherapy, prior to any treatment, and define the location of the metastasis at risk for being missed following the chemotherapy, not the disappearing metastasis, which will be resected in a field of resection where you have a large metastasis, small metastasis disappearing. These disappearing metastases don't count, but the ones count are the ones we really don't want to miss once the chemotherapy has started. And we have criteria to put fiduciaries, we place fiduciaries in these patients in interventional radiology before chemotherapy or just after 1 or 2 cycles of chemotherapy. And this is an example of a patient who had this metastasis ill-located between the hepatic veins, right and middle hepatic vein, and near the vena cava. The temptation would have been to do an ablation deep in there, in this location, where there would be a great risk of heat sink and incomplete ablation. So we placed the fiducial and we resected this patient with a 3 millimeter margin and a successful resection with no ablation, no heat sink, and there would have been a great destruction of liver tissue and probably would have been unable to re-resect these patients. When you have a local recurrence after ablation, you have to look at the cause of this local recurrence. The best result from ablation are ablations with 10 millimeter margin. This is the result of the Memorial Sloan Kettering, where they used 3D monitoring of ablation with CT done in interventional radiology. This 10 millimeter margin of ablation with best result of ablation has to be done under CT guidance. We see a lot of ablation done in the OR. Unfortunately, this ablation often results in underestimating of the margin or overestimating of the margin with huge areas of ablations which are completely unnecessary. When you do an ablation, you should also consider whether the patient is RAS mutant or RAS wild type. You see that even in patients with very small metastasis, a RAS mutation is associated with very high rates of local recurrence, in this case, 28%. If you look at the local recurrence here, patients with RAS mutant and RAS wild type tumor, patients with RAS wild type tumor are in red, and they really do not recur after ablation. Very rarely, only 8 out of 86, 9.3%. However, patients with RAS mutant recur very early after ablation, and this should be taken into account when you decide about ablation in patients with colorectal liver metastasis. Bilateral and bilobar metastasis have been treated with two-stage hepatectomy or ALPS procedure, and this is the scheme we have used at MD Anderson for our bilateral colorectal liver metastasis, with portal vein embolization done in sandwich between resection and between chemotherapy. This now can be done in an accelerated fashion in a hybrid room. Hybrid room is probably the future of liver surgery. And in this case, you could do at the same time resection of the left liver metastasis as a first stage hepatectomy, combined with a portal vein embolization, combined with a CT done immediately after the portal vein embolization. So you do 3 interventions in one at the first stage hepatectomy, and you can perform within 4 weeks a second stage hepatectomy. If you look at the survival of patients with two-stage hepatectomy, you see that we probably not curing patients with RAS mutation. However, I would submit to you that these patients with RAS mutation here are probably heterogeneous, and there's a group of patients, as mentioned by René Adam, who can benefit from surgery. Who are these patients? There are now 5 cancer-related pathways we recognize in colorectal cancer. And these pathways rely on driver mutations, TP53, KRAS, AP3, SMAD4, FBX, W7, NRAS, and BRAF. There are a lot of other somatic mutations and it can be very confusing, but none of the other mutations seem to affect the survival of patients with colorectal liver metastasis. And as you see here, this pathway, 5 pathways are here represented by these mutations, TP53, APC, RAS, BRAF, SMAD4, FBXW7, and the size of this circle, this blue circle, represent the frequency of these metastases. Out of these 5 metastases, 1 is associated with a better prognosis, and the 4 others are associated with worse survival. And this is indicated here in the multivariate analysis of survival of these 5 pathways which I presented: P53, APC, RAS, BRAF, SMAD4, and FBXW7. Interestingly, these mutations can translate in worsening of prognosis based on the number of mutations: 1 mutation, 2 mutation, 3 mutation. We were able to also analyze patients with Memorial Sloan Kettering with data presented by Dr. Schultz in the public domain. And we were able also to show the survival of these patients based on 1, 2, or 3 mutations here in these 5 pathways. So you can see here, related to our previous discussion, that in fact, patients who never had surgery, but were in this category of 0 to 1 mutation in blue here, have a survival which is 30% at 5 years nowadays, following chemotherapy only. Now the new kid on the block is circulating tumor DNA. Circulating tumor DNA is an emerging concept, and it is associated, when it's detected, with worse survival following resection of colorectal liver metastasis. This means there is minimal residual disease, and this can be detected with a blood sample. The circulating tumor DNA is in between the CEA and the PET scan. It's more expensive than the CEA, but certainly less invasive than a biopsy and less expensive than a PET scan. A ctDNA positive after surgery has a 100% positive predictive value for recurrence. Unfortunately, the sensitivity of ctDNA is about 60 to 70%. So if it's positive, certainly it means something. If it's negative, it may or may not mean cure. It may mean that recurrence may occur at a later stage of the disease. Perioperative ctDNA here has been used in the study of 48 patients before surgery and after surgery. Patients who remained ctDNA positive, while they were positive before surgery, had a very early recurrence and low recurrence-free survival. Overall survival, similarly, was very different in patients with positive and negative ctDNA postoperatively. Clearance of ctDNA after surgery, ctDNA plus minus, had similar recurrence-free survival and overall survival to patients with ctDNA negative after surgery. Perioperative ctDNA was associated, when it was negative, with detection of RAS TP53 co-mutation. So this co-mutation of TP53 with RAS is really a bad prognosis in patients with colorectal liver metastasis. What are we doing with this now? Well, we can devise new treatment following surgery and determine whether they can be used and provide similar results in terms of postoperative chemotherapy. ctDNA negative in this study will be assigned to a de-escalation. Instead of giving FOLFOX postoperatively for 4 or 6 months, we will give Xeloda. And in patients with positive ctDNA, we'll give FOLFOXIRI or FOLFOX, and the endpoint of this study will be the evaluation of recurrence-free survival at 1 year. So in the cancer journey of the patient, the mutations are key, and we have defined now 5 pathways with driver mutations which affect the prognosis of these patients. TP53 seem to be acting as a worse prognostic factor in association with RAS mutation. And TP53 mutation is a key component because it's acting behind RAS. And we have 40 alleles in the elephants and only 2 in human. And you see the big difference in the lifetime risk of cancer. So cancer mortality rate has been very different in these large animals with a lot of cells at risk for cancer because of these alleles. So we wish we could change our genetics and gain all those alleles. In the meantime, we'll keep talking about recurrence-free survival and we'll be very vulnerable with our thin skin. Thank you very much for your attention.
Jean-Nicolas, thank you very much for this very nice update. I think we learned a lot and it clarified many things. I don't know if there are any question to Dr. Vote from the audience. So, Jean-Nicolas, are you using these tools today to outside of a trial?
Yes, we're using these tools all the time. I mean, we're using as you saw, we're using the mutations. I gave you the example of the ablation. We're using this in ablation. We're using the mutations. You're talking about ctDNA or you're talking about
ctDNA is the most impressive, yeah. ctDNA, okay. For example, yeah.
So the ctDNA is very new. I want it to be short here. I removed 3 or 4 or 5 slides looking at ctDNA and showing that ctDNA can also give you the somatic mutation. So now anytime you see a patient in clinic, you can have not only a yes-no answer with ctDNA positive or ctDNA negative, but you can have a panel of mutation associated with ctDNA from a blood draw, a multi-gene panel similar to the multi-gene panel you get from tissue. So in answer to your question, we now looking at correlating this panel obtained from a blood draw to the panel we obtained from the tissue. We will believe it's going to be very tightly correlated right now. So we're going to use that because up until now, we had the molecular biology only in patients who had biopsies and studies before surgery. So this will avert the need for biopsy in patients in whom we have doubt regarding diagnosis. It will change, I think, the practice. Now, when you have to do also, I would say, debulking, or you want to be very aggressive, having ctDNA and somatic mutation based on the ctDNA, and patients with no mutation, only one mutation, we know they have a better prognosis. So we can select patients who will have better prognosis. Let's say you have a patient with a lot of comorbidity and you're on the fence and you don't know whether or not to do surgery, you can decide whether or not you want to do surgery based on the result of the mutation using a blood draw.
Maybe just a last short question on the other side of the spectrum. You have a patient with clearly resectable lesion. One lesion, for example, will require an anatomic resection. Should we now investigate that, or we can still go ahead without chemotherapy, which is the standard in many centers?
There's always the exception. I think chemotherapy or no chemotherapy. Chemotherapy should be used in almost all patients, but patients who just have had chemotherapy will not benefit from more chemotherapy. Patients who have had chemotherapy as adjuvant following the resection of primary should not get repeat chemotherapy.
Well, the question is neoadjuvant, if you want. I mean, if that, so yeah. You have a patient with a clearly resectable, I think most of us today, if it's clearly one single lesion or anatomic, we just go and take it out. And then we may give adjuvant therapy, but no neoadjuvant. Do you agree with that, or you see a change in this way of treating these tumors?
The solitary metastasis comes in so many different ways. The solitary metastasis may come, 5 years after resection of the primary, and I wouldn't give chemotherapy. But there's also the patient who just had chemotherapy following the resection of the primary. I wouldn't give the chemotherapy. So there are some patients who are intermediate, I would say, in this group, and you don't know where they are, and you would give them chemotherapy. Nothing wrong with 2 months of chemotherapy before surgery. Won't affect the liver, and you can do the surgery later and electively, and then it's a nice break from the patient. 2 months before surgery, 4 months after surgery.
Okay, thank you. That's another topic maybe for the next companion. Thank you, Jean-Nicolas. Thank you.
Thank you.
Thank you.